Okay. Good afternoon, everybody, and welcome to this webinar. Thank you for joining us and making the time to find out about what is a key issue for education for health professionals. This afternoon, I'm very pleased to say that we've got Professor Mike Woods talking through the draft recommendations from his report into our workforce, strengthening the education foundation. Some of you would have come to the workshop that we ran with Mike earlier this year, and also may have been party to some of the other consultations if you are part of the APRA Consumer Reference Group and other forums. Some of you may know Mike, but quickly, Mike's a professor at the Centre for Health Research and Health Economics Research and Evaluation at the University of Technology, Sydney. Prior to that, he was a commissioner at the Productivity Commission. And we're pretty much going to lead up to Mike to talk to you the usual process, typing in your questions into the chat box, and then Mike will make some time to answer questions at the end. So over to Mike.
Thank you, Joe, and thanks to the Consumer Health Forum for providing time for me to be able to talk through our draft report. This is deliberately a draft report as a vehicle for people to see where our thinking is, to see the evidence that we've based that on, the analysis that we've undertaken. All of the submissions are up online on our site, so people can look through those. And we welcome feedback on this draft report so that we can then put forward. There's a face sitting in the corner. See that?
Sorry.
And we do look forward to getting your feedback. And this is an opportunity. I'll go through the material to give you an idea of where it's heading, although no doubt some of you have already read the exec summary or even delved further into the report and looked at the recommendations. But this will be an overview to start with, and then we can proceed with some debate, which is the most interesting part. So just a little context to start with. As you all know, we have on average good outcomes from our health system, and they're delivered at reasonable cost. So we have high life expectancy, we have falling burdens of disease, we have universal health cover, and it all comes at a price tag of about 10% of gross domestic product, 10% of what the economy produces. And that sort of figure of 10% is roughly similar to what other developed countries spend, with the exception of the US, which is a significant outlier at about 16% of GDP. Okay, but when we look at what other health needs out into the future, it raises questions of what health workforce do we need? And although I'm only looking at the accreditation component of that in terms of the education that that health workforce receives, it has to be in context of, well, what health needs does the community have and what are they likely to have in the future? So we look at the issues facing the community, and we find rising chronic conditions are occurring. And so that raises questions about how can we spend more resources on preventative procedures, and also recognition that there's going to need to be long-term primary care support for people with chronic conditions. Ageing of the population, we see increasing numbers with long-term frailty and large numbers and increasing in overall size of those with dementia. Rural and remote areas, lower life expectancy, higher rates of disease and injury are well known, but again, primary care, long-term care, delivery of care where the population is, not just where the health workforce is important. with Indigenous populations. We sadly fully understand the greater health disadvantage that they have, and therefore the important roles that the Indigenous health workforce can play in adding to the healthcare and support for those groups. And also importantly, the social health interface, so that the health workforce needs to be able to work with the non-registered health workforces as well as the social care and support workforces in delivering services for people with disability, people in aged care, the homeless, people suffering family violence, the disadvantaged. All of these need much greater integrated care and support to assist them, to support them in their need. So why is accreditation of education important? And basically, accreditation is a process of authorising that a program of study, a degree or a certificate for a TAFE or related courses, deliver the knowledge, skills and professional attributes that are necessary for a person to be registered as a practitioner in Australia. So basically, the bodies who do the registering, the national boards, need to be able to have trust that a person who has successfully graduated from an accredited course has those knowledge, skills and attributes necessary to practice in Australia. And of course there are other attributes that the national boards look at. But it's a fundamental issue to make sure that the education that these students are getting is the appropriate one. The accreditation regulation, when it occurs, can of course either be a force for change or an inhibitor of that change. The accreditation system influences a lot of what happens in education. So the professional entry education that they receive basically is their foundation for their future careers, which is topped up then with professional development activities and the like during their career. If we have flexibility in the type of education that they receive, then that workforce in itself can become more flexible in its delivery of services over time. If we have greater interprofessional education, then it's entirely likely that the delivery of health services during people's career will also build on that foundation they have of interprofessional education and work more appropriately as a team. And as we saw earlier, that's sort of one of the fundamental needs of healthcare into the future. We want clinical placements during those early years of education to expose people not just to acute care in hospitals, where an awful lot of clinical education takes place, but in the community, in disadvantaged areas, in communities who are suffering significant issues of chronic care, or in remote and rural areas, Indigenous communities and the like. We want our future health workforce to be exposed to this wide range of models of care and delivery of services. Of course, the education accreditation process interfaces with a lot of other regulation and accreditation entities in the health and education spaces, and they need to be able to work cooperatively together. We also need for the accreditation function to align itself with the same directions and policies and reform programs that the national boards in their registration functions are doing, that AHPRA is delivering in its administration of the system, but also to have a common understanding of priorities and reform directions with the education providers who are developing the curricula and delivering education, with the employers of the workforce, so that they understand what is overarching government policy, and also obviously so that consumers have a greater sense of awareness of where policy is heading and what they can expect from the health workforce and the health system more generally. So that's the sort of underlying framework and context in which this study has been taking place. In that respect, consumers are central. Now, in our report, we've defined consumers in 3 categories, because here we're talking not about the consumption of the health services only, but the consumption of the accreditation system. So basically, there are 3 groups of consumers if you look at it from that context. There are the users of services, and that's ultimately what it's all about, and the patients, their families and their carers. But others are consumers of the accreditation system, if not of the health care being delivered. So that's students, because they receive the education and training that has been accredited, and the employers, because they employ the graduates of education services that so that they have the right knowledge, skills and attributes to become practicing health professionals. So that's how we define consumers of the accreditation system. But of course, the users of health services are central to the whole of the health system in its wider context. I mean, patient-centred care is basically what the system is there to deliver, and that needs to be reinforced at all possible opportunities. And therefore, consumers of healthcare have a very vital role to play in ensuring that the health and social care systems are delivering the right care in the right way at the right times and in the right places. And so we need to harness that knowledge of the consumer experience and what the consumers are expecting. The national law talks about community involvement or community members in national boards. It doesn't define what those community members are, but there's a requirement that there be at least 2 community members on national boards. But it's a broadly defined term, and therefore has been interpreted differently by different boards. And so there is no commonality across the current 14 professions or 14 national boards, soon to be 15 national boards once paramedics comes in, and 16 professions once there's a separation between nursing and midwifery as 2 separate professions, but operating under the one board. The approach that we've taken as part of this review is that there was a review of the whole of the National Registration and Accreditation System back in 2014, but that was a review that dealt with the system as a whole, the scheme as a whole, and therefore wasn't able to get into detail on particular parts. And so health ministers, in looking at the outcomes of that scheme reviews, well, we want to look at the accreditation system in greater detail, and hence this current inquiry. There are 3 broad themes that we've taken in undertaking this inquiry. Now, there's detailed terms of reference, but we can break them into these 3 groups. One is to how to make the current system more efficient in itself. So without making too many changes, how can we get rid of duplication and overlap and have greater consistency and collaboration, etc. A second stream is to look at the effectiveness of health education. So how can we ensure that the accreditation system is helping the education providers, the university, TAFEs and others, to deliver the right education for the future workforce, and also to look at the governance arrangements for the accreditation system to make sure that it is promoting a reform that is going to lead to more beneficial education and ultimately more appropriate health workforce into the future. In terms of our findings, the accreditation system, won't surprise many of you who have had to deal with it, it's somewhat fragmented and cumbersome. We've got 14 national boards, we've got 14 accreditation councils or committees, and we have other regulators in this space. We have some limited transparency and accountability as to who's doing what and how they report it. We have in every accreditation standard across all 14 professions very strong words about interprofessional education, but when we look at it in detail, we find that the actual practice of interprofessional education is somewhat lacking. Now, if the education on a team-based approach is lacking, then it's not unexpected that the delivery of health services on a team-based approach is also lacking. We have inconsistent assessment processes and reporting, so that if you happen to be a university who might have 5 or 6 different courses of health study, whether it be physio or occupational therapy or nursing or whatever, you'll find that you have 5 or 6 different assessment processes, 5 or 6 different requests for information, much of which is the same underlying information but requested in different ways at different times by different groups, which is, again, just fundamentally inefficient. We find there are all sorts of restrictions on innovation. There are still some input-based requirements that you must do the following, irrespective of whether there's a good educational outcome that derives from it. We have all sorts of inconsistent approaches to work readiness. In a number of professions, once you've graduated, you can apply for registration, but in others, you then have to do another year or more in some form of a work-ready program, or you might have to sit an additional exam or exams on top of graduating from your course of training. And of course, there are other regulators in space. The higher education space, you have the university regulator, TEXA, and the vet sector regulator, ASQA, doing in some cases much the same things as what the health regulators are looking at with their accreditation processes. Now, fundamentally, what we want to do is to have a system as a whole, a scheme as a whole, and an accreditation system within that delivers on the objectives that are in the national law. And when we look at them, we find that the objectives are the sort of things that you'd expect. One, that you protect the public, that you deliver safe, high-quality healthcare. Another is that you have high-quality education and training, that there is rigorous assessment of overseas trained health practitioners to make sure that they meet Australian standards, that the system facilitates access to services in the public interest so that the services being delivered, health services, are those that the community needs, reflecting what their healthcare concerns are in places where they are, at times where they are able to access it. And finally, and very importantly, pardon me, there is an objective that says that the scheme should continuously develop a flexible, responsive and sustainable health workforce. And each of those 3 things, flexible so that it's able to accommodate team-based healthcare delivery, that it's responsive to the emerging needs of the community, and that it's sustainable, that it comes at a cost that individuals and taxpayers in general can afford to meet into the future. So yeah, they're all quite sound and reasonable objectives, but not necessarily all of them get equal attention all of the time. And our report stresses the importance of looking at all of the objectives rather than just some of them. In terms of the model of governance and some of the desired outcomes that we're looking at, fundamentally we see that we should focus separately on the regulation of the individual practitioners. That's the registration process to make sure that the health workers are practicing in a safe, quality way, and that the accreditation of programs of study is a separate but related issue. We've identified ways of improving efficiency in the processes by way of having greater consistency, by having, when I find my glass of water, there we are, by having greater commonality of accreditation standards. Now, that was something that came across very clearly in our forums with consumers, that how come there are 14 sets of standards? They all seem to say roughly the same, but basically they use different words and in different structures and define it differently, so that the terminology varies, yet the underlying principles seem to be somewhat the same. The assessment processes, why are they different when we're looking at trying to achieve the same sets of outcomes from the accreditation process and the information requirements and the like. And also, how can we make sure that we stop overlapping with other regulators who are already doing some of this, being TEXA, ASQA and the Australian Commission on Safety and Quality in Healthcare. So it's a question then of identifying what they already do, that they do competently and thoroughly, and not repeat their processes. A second area, apart from efficiency, is some recommendations on how to improve effectiveness of the system so that we get better collaboration between health and education, to develop this responsive health workforce. So we focus on outcomes from the education process and from the accreditation of that, on inputs, that we strengthen cross-professional approach to interprofessional education, that we promote clinical placements which focus on workforce priorities, and that we have a common approach to competency standards, so that there is a clear understanding across the professions of what the competencies are. We also see the importance of having an integrated health and social care system, and so we've put forward some recommendations to have a situation where the non-registered professions, both health and social care professions, can have their courses accredited through the system without necessarily impacting on their non-registered status. We also want to make sure that the way that overseas trained practitioners and offshore programs of study are assessed are consistent with what are the requirements in Australia. We want to improve consistency in the appeals processes, and we've got some recommendations there. And importantly, we want to make sure that the reform programs for the future workforce are understood by all parties that help create and regulate the health workforce. This diagram basically summarises what we're looking for in a governance model, so that you have the AHPRA and its management committee as one stream of activity, a single health education accreditation board, as a middle stream, and national registration boards sitting on the other side. That's because our study can't look at the governance of the registration boards. That isn't in our terms of reference, so they remain unchanged on that side. Just to go through a couple of those issues, let me see that I've got all of the right bits. Yep. There are some recommendations that are specifically related to consumers, and so we're looking at one that says, well, you can read it on your screen, but that all accreditation standards should require education providers to demonstrate the involvement of consumers, broadly defined as I described before, in the design of education and training programs, curricula, and also to make sure that there's promotion of patient-centred health care. So the question that I'll come back to at the end of my presentation, which is only a minute or two away, is to say, well, you know, where can consumer input, and in your case I'm talking about the users of the services, their families and carers and others, where can that best have impact? Is it in the development of professional competency standards? Is it in the design of the education and training programs and the curricula? Is it in the assessment of those programs and the assessment of the education providers? Or is it in all three or some combination of them? And I'll to ask whether that recommendation does capture all of the appropriate roles and inputs from consumers, being in this case the users of the health system. A following recommendation looks at the current AHPRA community reference group and asking, is there a way to make the accreditation part of the process more central to the functions of that group, and also to the resource for accreditation authorities and our proposed accreditation, single accreditation board, to be able to get some input from consumers in their thinking. So we hope that the increased commonality of accreditation processes will reduce some of the repetitive documentation that the consumer reference get, and we're interested in whether community members, consumers in this case, can be better resourced to limit their sort of capture by interests of the professions themselves. So we are looking at the type and amount of support and training that is being given to consumers. In terms of the timelines for our inquiry, many of you have come across our discussion paper that's on our website that we put out in February, or may have come to some of the forums that we held during March, including the consumer workshop in the middle of March. Then there was a process of submissions, and a number of you have put in submissions, and thank you very much for doing that. We went then through a process of doing our own analyses and looking through the submissions carefully for sound evidence and good reasoning. We put out the draft report a week ago, and we're now looking for submissions, and we will put forward a final report at the end of October. So let me go back to there to start with, and so whether you have any general points that you wish to raise about the report as a whole, or the processes, and then we can go on to the two specific recommendations and any other recommendations that you think we should propose in our report. But in this model here in particular, I just want to emphasise that we're trying to bring together all of the current 14 accreditation authorities in terms of some of their functions, like setting the accreditation standards, pushing for interprofessional education, of having common processes, of having very clear delineation of responsibilities with other regulators. And so that would all be done from one single board, which would drive those reforms. But then we would have the individual profession-based accreditation committees, whether they are 14 or whether they amalgamate themselves voluntarily into a smaller number, to act with the assessment processes, but subject to the overriding policies and guidelines from that one single accreditation board. So that's our model, but have some general discussion first, and then we can head on to looking at the recommendations in particular. So I notice there's been a little stream of chat, which I've tried not to be diverted too much by as things are heading past, but how do you want us to deal with it then?
So we're now,
Dean
is putting up questions now, but if you can...
Okay, so first one, so I say who that's from. So Rachel Yates is talking about the need to encourage and promote stronger and effective cross-sector, cross-ministerial action. I haven't seen what's the preceding part of that discussion, but certainly, oh, there we go.
That's what everyone else is saying, just the tab on the top right.
Sorry? Come and drive this
Sorry,
thing
if you
from
need to
me.
jump between, just click on the top there, but you can see the question there now.
Oh, okay. I'll get on to the one that's just popped up on the big screen, but in terms of the chat, if I can respond to that for a second, it certainly is important that we try and bring this scheme together. So each of the professions is important, and the registration of the individual professionals, practitioners, is important, as is the assessment of courses for them, but the scheme needs to act in a more cohesive manner. So we've got a question here. Alan Groth says the issues that we've talked about are exactly the issues policymakers need to grapple with to improve outcomes, Indigenous, remote, etc. Are they receptive to these messages? Well, that's always a very good question. What I would prefer at this point of the inquiry process, in fact, is that ministers stand aside and let the inquiry go through to its conclusion. So we've got a draft report out, we're wanting feedback on that draft, we will then submit a final report, and that's then when ministers can come into this process. But it is an independent report. I'm not writing it on the basis of whether ministers will necessarily agree to it or not. I'm writing it on the basis of what I and my team think are in the best public interest, and then we'll see whether ministers are receptive to those messages. But I would certainly like to have ministers sit and watch the debate to understand the views of all the various stakeholders and to look at the final report and then to come to their own views. Hopefully being persuaded by the strength and logic of the narrative that we put forward. Here's a question from Rachel Yates. Given students are an important consumer group, yes, certainly consume the accreditation system. On the ARPA community reference group, there are other processes, Rachel, by which they do contribute. There is, obviously, academic boards have very strong processes of engaging students, and we would expect through the accreditation process that the accreditation committees that we're proposing will also ensure that there is strong student feedback through that. I personally would like to see a community service users group, i.e. the consumers of the health services, to have a forum that is focused on their situation. But we do in our report recognise that there are multiple consumers of the accreditation system, and each has an important role to play. And Helena's put up a comment there as well. Okay, next question, a comment. Community input, very important. We'll get professional. Well, that is a useful comment to make, and certainly our inquiry is concerned to make sure that consumers are properly resourced to give them the tools and the confidence to be able to put forward an independent consumer view and to be able to consult with their consumer bases. And most of the consumers who engage do have strong bases that they work from. And of course, there's the Consumer Health Forum itself, which is a sort of overarching resource that can be drawn on. So we are concerned to avoid what we call capture of consumers by professional groups. And the best way to do that is to provide appropriate resourcing of them, but also to make sure that they remain well-founded in their home-based community groups that they arise from. Ministerial oversight with respect to development regulation sits with health ministers, Commonwealth Education Minister. Yes, quite true. There is a panel looks at the accreditation of education, professional education, and we have been working with that panel to make sure that what we're doing in the health education space can carry across to other professions. But we do want to make sure that there is greater interaction between TEXA, who is the higher education regulator, and the Health Education Accreditation System, and trying to build those links in that process so that there is a greater understanding across the two. In terms of the ministerial oversight, yes, there are sort of two streams, but I think underneath that level of ministerial oversight, we can certainly get much stronger action happening across health and education in the ways that our report proposes. We finished already.
Yeah, that was all the questions.
I have a question for you, Mike.
Yes.
It's Joe.
Well, yes, Joe.
When you look at the diagram that you put up,
Yes.
and have the new Health Accreditation Board, what would you say to people saying, why are you adding in another layer?
Yes, that's a very good question.
Isn't that inefficient, and do we need more bureaucrats? How are you going to respond? How does that actually simplify things?
Very true. How do I get that picture back up?
Don't ask me.
There we go. Look at that. Somebody was clever. Okay, so yes, I could imagine that there will be some groups out there who raise exactly that question, Joe, and say, oh, you're just making it more complex. Oh, how does this actually help? Well, it's quite a simple answer to that. One is that at the moment, because we have 14 national boards and we have then the 14 accreditation bodies sitting underneath that, that we have 14 sets of accreditation standards, we have 14 attempts to have interprofessional education, we have 14 sets of funding principles, we have 14 sets of operating guidelines, and they all report back to the national boards, who themselves, in fact, are the final deciders of whether a program of study is approved or not. So the accreditation entity doesn't actually make that decision. It can make recommendations, but the national boards actually have final say. They also have final say on the accreditation standards. So if they don't like the standards that are being proposed, they can block their implementation. So what we're saying is, let's have a stream of activity that is national boards. Let's have a stream of activity that is accreditation, and let's have one single accreditation board that drives and approves the accreditation standards. So not 14 standards, but let's have one board making sure that those standards are tied together and that there is commonality in their frameworks and structures and the like. Let's have one board that drives cross-professional education. Let's have one board that works with TEXA and ASQA and the Safety and Quality Commission to make sure that there is no overlap, rather than having 14 memoranda of understanding with TEXA in different ways and done differently. Let's make sure that the assessment processes have common information requirement universities, so that they're not getting 5 or 6 different approaches for their 5 or 6 different faculties for one set of information. So all of that's driven by one board, and then you have the actual assessment processes done either by the current 14 committees, but within that one set of frameworks, or if in fact some of those committees want to amalgamate and work in a collective manner, then let's do that as well. So it simplifies and drives reform. What we found is that there is common agreement on a lot of things that should happen, but they don't happen, or they happen slowly, because there's no integrative mechanism. There is a forum, and it is well run, and we're very supportive of it. But it's voluntary, and it's then subject to the individual decisions of the individual boards as to whether they agree or don't agree and the like. So let's take accreditation out at its own strength and responsibilities and accountabilities, and let's have one board that drives all of this reform and is accountable for making it happen.
So what about, how would you respond then if, say, that, and I'd be interested to see what the national boards have had to say about such an idea, but what about, well, we're different. We would lose, I came from Queensland, where we all know everybody, Queensland's very different from everywhere else, and WA is different.
They're all special.
And we're all special, and all the professions are special, but they do have some unique characteristics. So how do you make sure this doesn't go to a common lowest denominator and actually lose the professional competencies and skills that are needed?
I'm glad you raised that one as well, because again, we could expect some groups to raise that question. And again, there's a very simple answer to that. What we want to do is preserve the best practice of a profession. So if you go to a physio, first and foremost, you want them to be a very good physio, or an OT, or a medical specialist, or a nurse. So you want them to be proficient in the delivery of that form of healthcare, but you also want them to be able to work collectively as a healthcare team, because as we saw with the rise of the chronics, the frail aged, all of these issues require integrated care, not just care by a set of individual professions. So what we're doing is, in fact, we've got a recommendation in there so that the individual profession-based national boards get to decide on what are the competency standards for that profession. So when you look at the accreditation standards for the professions, they are all underpinned by what is this person meant to be competent in doing. And that, of course, is their professional expertise. And so we're saying at the moment we've got some of the competency standards are developed not within the NRAS system at all. They're developed by professional associations or others. We're saying give that role to the national boards. That way they can be sure that the competency standards which underpin the accreditation standards are fit for purpose for that profession. But then let's overlay that with a more integrated approach in the education of the workforce so they can get to understand how to work collectively to deliver the sort of healthcare that our community needs. So we do need the two parts of the system, when we need the national boards to have trust in what the accreditation entity is doing, and we need the national boards to be prescribing what are the competencies that that individual profession needs to have to deliver its services. So I think we've covered that one quite well.
Any other questions?
Can I go back again, if somebody can get me to the slide. So I'd just like to go through those two. Yeah, now let me just move to the two specific recommendations. And I'd be interested if anybody has any questions on whether there should be any change of wording or why have we said what we have on either that one, which is looking at where consumers, and we're talking in this case consumers of health services, can add best input, and is it all three or is it more than three? What's your feedback there? And also in terms of expanding the terms of reference and resourcing of the community reference group. So if there are any particular questions on those or comments, suggestions, input, that would be terrific. And if not now, please drop us a line. A submission can be an email, a submission can be a one-page document, or a submission can be a big glossy, but we don't particularly want big glossies. We just want good information supported by sound evidence. So anything on either of those two?
I'll do another talking head. Hi everyone, you're meeting the CHF staff today.
Hello.
I'm Rebecca, I read policy and research. Mike, has AHPRA been consulted about the expanding role of that?
Yes,
tag?
well,
And what do they think?
the Agency Management Committee, in fact, we've consulted far and wide. If you go onto our website, you'll see submissions. You'll see a joint submission from the Agency Management Committee, AHPRA's management body, and the national boards. But you'll also see a separate supplementary submission from the Agency Management Committee where they're saying, as do the national boards, yes, you know, reform does need to happen. Reform has been slow. There needs to be a change of process to drive it. Now, they've come up with different models, and in our report, we in fact go through as our second option is the AHPRA model. So we specify that and we look at it and we say that's got some strengths, and in fact we're open to the idea that maybe these functions can be built into the AHPRA's Agency Management Committee, but if so, it would have to be more empowered, and it would have to be committed to driving the reforms, not just be yet another coordinating function that still is based on 14 accreditation profession-based systems, all happy to work cooperatively but not actually drive that integrative reform that we're looking to achieve.
Great. We've got another one on that topic from Helena.
Helena, will the Accreditation Board collaborate with Community Reference Group? Certainly what we want to achieve is for the board to be able to use the Community Reference Group as a resource, and for the individual accreditation committees to use that as a resource. Question of consumer representatives on the Accreditation Committee, we're open to that idea. This is a draft report. We've put forward some proposals, but if people want to argue and give evidence supporting particular ways in which that can be achieved, then come back to us, Helena, with arguments as to the right way to deal with it. And I see a comment then from Tim Benson underneath that as to whether the community reference group, you're not sure that that is the right body, a combination of councils, including some of their community members. Okay, so we've got some debate happening there on what is the right way of dealing with that. I think we all have a common intention, and that is to ensure that the consumer voice is available to the accreditation process and in fact is embedded in the accreditation arrangements, including the assessment arrangements. So please come back to us with your ideas. We're capturing these as we have today's session, but we're also amenable to, as I say, an email, a page, whatever you want to send into us with ideas and supporting evidence. Arguing.
On the note, CHF, as many of you listening will know, are doing our own submissions. So
Absolutely.
If you want to input into our submission, I dare say Mike would like individual submissions as well, so please do those. But many of you have my email. It's r.randall@chf.org.au. Drop me a line if you'd like to be included in the CHF submission.
Excellent.
Great. Any more questions? Any last questions? One from Alan Groth there. Mike?
Propose support a consistent approach to ensuring cultural responsiveness. Well, absolutely, and in fact, we're meeting next Monday afternoon down in Melbourne to discuss that particular issue in much greater detail to make sure that we embed it into our thinking in the final report. So we are very sort of across that issue and understand its importance of cultural responsiveness, and we're taking further steps to make sure that we fully understand the issues and where appropriate for our particular focus on the accreditation system to make sure it's reflected there.
Any last questions? Any last comments? Okay.
No.
Excellent.
So you've got the email for the review there, and you've all got contacts with CHF. Thanks for tuning in, guys. I'll let you wind up, Mike.
Thank you very much. So we have appreciated the support from the Consumer Health Forum. We had that workshop back in March. We've had submissions, we've had discussions, and we've had discussions and representation of consumers through a whole range of other processes and inquiries. So thank you for making the time available to help us make sure that we properly reflect your issues and concerns. Thank you again.
So thank you.
Thank you.